Hello and welcome to today's presentation, which will focus on screening adolescents for alcohol and other substance use and related behavioral health risks. I'm Christina Dryman and I'll be presenting today's session. I also want to recognize Tracy McPherson, who serves as joint faculty on this initiative and has led many of the adolescent SBIRT initiatives at NORC. The information shared today is developed by NORC at the University of Chicago and its partners with funding from the Conrad N. Hilton Foundation. So there are three core components of adolescent SBIRT: screening, brief intervention, and referral to treatment and follow-up. So in today's session, we're going to focus on screening. And screening is the process of assessing adolescents' substance use and the associated risks using validated tools. Screening should include assessing risk of a broad range of substances. So this includes alcohol, tobacco, marijuana, vaping, illegal drugs, and non-medical use of prescription medications. And so any amount of substance use, starting with just mere experimentation, is concerning for young people due to the potential health impacts as well as the associated risky behaviors and future drug use. Most validated screening tools are brief and can be administered in less than 5 minutes. Screening tools that assess substance use can be used alone or in combination with mental health screening tools. When used together as a behavioral health screen, the time to administer can range anywhere from 5 to 20 minutes. And so it's important to know whether the screening tool you have selected to use has been validated for the specific age group you're working with, as well as for the mode of delivery, either verbally or virtually on a computer in which you plan to administer it. And so screening is an important component to jumpstart the SBIRT process. And oftentimes, if you don't ask, it's likely the adolescents will tell you about their substance use. And so there are a number of recommended substance use screening tools that have been validated for use with adolescents and young adults aged 12 and older, including the CRAFT, the S2BI tools, which are accurate and commonly used. And there are also brief validated mental health screening tools, such as the PHQ-9a and the Cssrs for assessing risk of depression and suicide. And so I'll talk more about these screening tools in a moment. And also in the resources section of this session, you'll find more information about a wide range of additional tools. So regardless of the screening tool used, asking about substance use may be especially difficult with adolescents who may not want to admit or discuss their use. So successful screening can be enhanced by the memorization of the tools and practice of the conversation skills required to put the adolescent at ease. And so whatever the tool and method of instruction, including the conversation about substance use and screening, is a good skill for any nurse, social worker, or medical provider to practice in order to naturally transition into the suggested tools in this module. Substance use screening questionnaires can be verbally administered by a staff member or a practitioner, or self-administered by the adolescent using paper and pencil or electronic devices such as a tablet or a computer, depending on the screening tool. And there's no one correct approach that suits all settings and situations, but there are several considerations that may favor one approach over the other. So self-administered screening by the adolescent may save time and be most efficient because different members of care teams, such as a front desk personnel or medical assistant, can initiate screening as a part of the check-in process. In addition, the adolescent could complete self-administered screening in the waiting room or the exam meeting room prior to the visit with the practitioner, as long as it's possible to sort of create a sense of privacy. And with self-administered screening, it's important to inform the adolescent or parent caregiver, if present, that the adolescent should complete the form on their own. And the practitioner would then review and verify self-administered responses during the visit. The literature also suggests that self-administered computer screenings is valid and time efficient for adolescents, and that some adolescents may actually prefer this method. Adolescents may also feel more comfortable and provide more accurate responses using self-administered brief screening due to the sensitive nature of the topic. And electronic screening may be especially ideal because of the sense of privacy it confers and the widespread use of digital communication, and also the tendency of adolescents to really sort of self-disclose quite freely via digital communications. And so when an adolescent is responding to screening questions in a language other than English, self-administered screenings may also be more feasible and efficient. However, when there is a concern about reading comprehension or literacy, staff or practitioners must be more involved to assist the adolescent and may need to administer the screening verbally. So how do you discuss substance use with the adolescent? Practice the following conversations to introduce the topic of substance use with the adolescent. So to start, you may say something like, in order to help you get correct services, I'd like to ask you some questions about your health that I ask all of my clients. These questions will help me to get to know you and provide you with the services that you need. Is that okay? Another option is to say something like, as a way to help me get to know you, I'd like to ask you some questions that I ask all of my patients. Is that okay? Confidentiality can play a vital role in providing healthcare to adolescents. Research has shown that adolescents who are aware of confidentiality are more willing to seek healthcare compared to their peers who may not have the same sense of awareness. State laws govern minor patient rights to confidentiality of information shared with healthcare providers about substance use, but states vary as to whether or not a minor can confidentially receive substance use treatment services. Also, you should explain the full confidentiality policy regarding the disclosure of sensitive issues directly to the adolescent at the very beginning of the assessment. If the adolescent is willing, it can be helpful to explain the confidentiality policy to both the adolescent and the parent or guardian at the same time. One example of how you might convey an assurance of confidentiality is by saying something like, everything you tell me will be confidential unless I hear that you're harming yourself or someone else, or you tell me that you've been a victim of abuse. I'll keep our conversation about your substance use between us unless you agree to include your parents. Do you have any questions for me about confidentiality and its limits? So there are different steps that you can take to ensure confidentiality, and those include establishing a private time for screening and a private time for discussing the results, keeping follow-up visits confidential, talking about referrals, discussing any procedures that may break confidentiality inadvertently, and clarifying risks of releasing medical records. So we're going to first talk about the screening tool known as the CRAFT plus N 2.1. So the CRAFT tool is one of the most popular substance use screening tools for adolescents and young adults aged 12 to 26. It's also recommended by the American Academy of Pediatrics Committee on Substance Abuse. Excuse me. The CRAFT is designed to ask age-appropriate questions about risky alcohol, drug, and nicotine use, and screen adolescents for lifetime alcohol and drug use disorders simultaneously. It's brief so that it can be easily integrated into routine care. And the CRAFT developers are strongly encouraging practitioners and organizations to move from the original version to version 2.0 or higher. These versions take advantage of improved psychometrics and how the tools gather information about a fuller range of substances, so it leads to more accurate screening of adolescents. However, circumstances do not currently allow for that shift, perhaps due to it being incorporated into the workflow or electronic health or medical records. Each version of the CRAFT is still valid and useful. All versions of the CRAFT may be administered via interview or self-administered either electronically or in paper form. So part A of the CRAFT plus N 2.1 asks about the number of days in the past 12 months the adolescent has used any alcohol, marijuana, illegal drugs, and prescription and over-the-counter medications for non-medical reasons, tobacco and nicotine, including e-cigarettes. If the adolescent reports any days in Part A, then you would administer all 6 questions in Part B. If the adolescent answers 0 to all in Part A, then only the CAR questions, C-A-R questions in Part B should be asked. And so here are the 6 questions of Part B, which create the CRAFT mnemonic acronym, which makes it easier to remember. And the CAR questions, or the CAR question is the first one, the C-A-R. So in order to ensure accuracy of the assessment, it's important to ask the questions exactly as they're written. And these screening tools can be tested using the specific wording, and any deviation from the original wording may alter the type of response given by the adolescent. However, you may further elaborate and explain the question if the adolescent does not understand how it's written. Each yes answer from the adolescent for any question in Part B scores 1 point each, and a no answer scores 0 points. So you'll tally all the points accrued in Part B to obtain a final score. And so a score of 0 to 1 can indicate that there are no problems. However, a score of 2 or more can indicate that a more significant problem may exist and a brief intervention is indicated. However, the 2+ cutoff score is not a hard and fast rule. Practitioners should use clinical judgment to determine if further assessment and services are needed. So next we'll talk about the S2BI. The S2BI was created by Boston Children's Hospital and introduced in 2014. Screening to brief intervention, S2BI, is a brief, validated electronic and paper screening tool for youth aged 12 to 17 years. The S2BI can be self-administered or conducted as an interview. This relatively new tool begins with a single question to assess the frequency of substance use in the past year. And so the substances screened in the S2BI are categorized into 8 categories, including alcohol, marijuana, cocaine, and prescription drugs. And the tool is based off of the Diagnostic and Statistical Manual of Mental Disorders, also known as the DSM-5, Diagnosis for Substance Use Disorders. And the brevity of the tool enables it to be easily integrated into routine care for adolescents with little burden to the practitioner. And it should be administered to the adolescents during each visit in whichever form is most convenient for the healthcare setting. Before administering the questions, begin by reading the following statement. The following questions will ask about your use, if any, of alcohol, tobacco, and other drugs. Please answer every question. The S2BI begins with 3 initial questions that ask about how many times the adolescent has used tobacco, alcohol, and marijuana in the past year. If the answer to all 3 questions indicates that they have never used any of these substances, then the practitioner stops the screen. If the answer to any of the 3 initial questions indicates use in the last year, then the practitioner should ask the remaining 4 questions about use of prescription drugs, illegal drugs, inhalants, herbs or synthetic drugs, and then provide brief intervention based on the level of use as follows. So no use on the initial questions. You would just provide positive reinforcement to the adolescent. If the adolescent indicates use once or twice, you'd want to provide brief advice. If the adolescent indicates monthly or weekly use of particular substances, then you want to provide brief motivational interventions, which means assess for problems, advice to quit, or making a plan on how to quit to reduce the use and risky behaviors associated with use. For weekly use providers, or for adolescents who mention weekly use, it's also probably advisable to refer the adolescent to treatment. The screening score is used to determine the level of risk and also the appropriate level of brief intervention based off of the adolescent's answer to the S2BI. So now we'll just briefly talk about some other risk factors. So in addition to substances, the United States Preventative Task Force recommends screening adolescents ages 12 to 18 years for depression and clinical practices that are equipped to perform or provide a referral for diagnosis or psychotherapy and follow-up. So a recommendation was not available for adolescents younger than 12 years old. However, it's logical to inquire about depression and substance use with adolescents at the same time, given that these occurrences are often comorbid, and depressed adolescents are sometimes using substances to feel better or worse. And adolescents that are using substances are sometimes looking for ways to cope with uncomfortable feelings. And so the United States Preventative Task Force did not recommend one depression screening tool over another. So this section reviews one of the most popular depression screening tools that has been adapted for adolescents, known as the Phq-2a. So we'll talk about that briefly. The PHQ, referred to as the Patient Health Questionnaire 9A, is a very popular, brief, reliable, and validated screening tool to assess risk of depression for adolescents and young adults ages 12 to 18. And the PHQ-9A has 9 items and takes about 2 to 3 minutes to complete. It's available in paper form as a clinical interview or as a self-administered tool. The PHQ-2a is comprised of items 1 and 2 of the PHQ-9A, and it's used as a pre-screening tool to determine if the full PHQ-9A is necessary. And these items focus on depressive symptoms in the last 2 weeks. The PHQ-3a is comprised of items 1, 2, and 9 of the PHQ-9A, and it's used as a pre-screening tool for depression and suicide risk to determine if the full PHQ-9A and an additional suicide screening tool, such as the Columbia Suicide Severity Rating Scale, or the Cssrs, should be administered. The full PHQ-9A and Cssrs provides more detail on the severity of risk for depression and suicide, including the presence of suicidal ideation, having a plan and intention, and also acting on that intention. So to administer the PHQ-2a or 3a, you'd ask these questions to the adolescent. Like substance use screening tools, it's important to ask them exactly the way that they're written. Items on the PHQ-2a and PHQ-2 or 3a are assigned points from 0 to 3. And so a score of 2 or 3 to either item 1 or 2 is a positive depression pre-screen. A score of 0 or 1 to both items 1 and 2 is a negative depression pre-screen. A score of 1 or higher on item 3 of the PHQ-3a is a positive pre-screen for suicide risk. And if there is a positive screen on either the PHQ-2a or 3a, the remaining questions of the PHQ-9a shown here should be administered. And as you can see, the items are picking up on symptoms of depression, such as disrupted sleep, appetite, fatigue, concentration, and other symptoms. The PHQ-9a's scoring structure is exactly as the PHQ-2a and 3a. The 9A is scored by adding the total amount of points for all 9 items to assess depression severity. So if the PHQ-9A score is 10 or greater, this is positive for depression, and further diagnostic evaluation for major depressive disorder according to the DSM-5 is warranted. For adolescents, depression severity correlates with the PHQ-9A scores as follows. So a score of 20 to 27 would indicate severe major depression. A score of 15 to 19 would indicate moderately severe major depression. A score of 10 to 14 would indicate moderate major depression. A score of 5 to 9 would indicate intermediate or mild depression, and a score of 4 to 0 would indicate no depression. And lastly, we'll just talk about the Cssrs. So again, suicide is the second leading cause of death among youth and young adults aged 10 to 34. Substance use is the second most common risk factor for suicide, with alcohol and drug use increasing risk 10 and 14-fold respectively. As such, it's critical to screen for suicide risk in addition to alcohol and other drug misuse. So the Columbia Suicide Severity Rating Scale, commonly referred to as the Cssrs, or the Columbia Screen, is a 6-item scale originally developed to assess risk among adolescents with depression. And so the tool assesses for the full range of ideation and behavior, including intensity, frequency, and changes over time. Various versions are available that assess for lifetime and recent behavior, as well as initial visits versus since the last visit. And so the Cssrs is a validated and evidence-based tool for people of all ages, and it is also available in over 100 languages. So this version is copied from a pocket card designed for adolescents. And so all items of the Cssrs are yes/no questions. The first 2 questions assess general ideation. The first question is sort of a passive ideation or the wish to be dead. And the second question is more active ideation or having any thoughts of killing oneself. A yes response to having any thoughts of killing oneself triggers the remainder of the Cssrs questions. And these assess for the presence of a plan, intent upon acting on thoughts, having both a plan and intent on carrying out that plan, and then actual suicidal behavior, both lifetime and recent. So the Cssrs color codes responds to, the color codes responses correspond to a low, medium, or high risk. And so here are the levels of risk that correspond to the Cssrs color codes. Low, moderate, and high, which correspond to the recommended action. And the actions range from a behavioral health referral to a behavioral health consult, and also patient safety planning. Again, clinical judgment should always be used to categorize patients into risk levels. Just want to mention a few other resources. As I mentioned earlier, screening tools have been validated for specific age groups and modes of administration. And so here's just a list that can help inform your selection of a screening tool. And here is a resource list with descriptions of other validated screening tools. Some focus on alcohol only, while other screens for a range of substances. And so if you'd like to learn more on what I've shared with you today, we recommend the Learner's Guide to Adolescent SBIRT, Module 2, Screening, and it provides further understanding on how to screen and gives a more in-depth discussion of the screening tools and how to score them. More information also on screening for adolescents, including additional tools, is available in Part 1 of Using SBIRT to Talk to Adolescents About Substance Use, which is an on-demand webinar series available at sbirt.webs.com/webinars. That'll conclude today's presentation. Thank you for your time.